Hello, this is Kim Jong-il. Today, we are going to discuss arch length preservation. This will be the first part of the lingual arch. First, let's cover the terms. If the mandibular first molar moves mesially because of the extraction of the mandibular second deciduous molar, it must be moved back to gain space. This is called space regaining. If the mandibular second deciduous molar remains, we preserve this space and use later. This is called space maintaining, or arch length preservation. We sometimes move the mandibular first molar distally to gain space. This is called molar distalization, and in this case, the mandibular second molar is likely to be impacted. We preserve the arch length for non-extraction treatments. What would be more important in non-extraction treatments? The crowding of the maxillary anterior teeth or the mandibular anterior teeth? The answer is the crowding of the mandibular anterior teeth. Therefore, I recommend use of mandibular lingual arch rather than TPA for arch length preservation. Dr. Janelli said that about 86% of patients experience crowding in the mandibular anterior teeth at Hellman's dental age 3B, which is when the lateral tooth group exchange. 77% of these patients were reported to have been able to preserve the arch length by using the lingual arch or lip bumper in the mandible. The lingual arch is commonly used when the mandibular lateral incisors erupt lingually more than the central incisor does. If we don't treat this, the mandibular central incisors may also position lingually later, resulting in insufficient space. The lingual arch is composed of the band of the mandibular first molar and a 0.9 mm stainless steel arch wire. A U-loop should be applied to the anterior region of the first molar, and the anterior wire should touch the mandibular anterior cingulum. There is also the precision lingual arch besides lingual arch. The precision lingual arch can be used for enlargement and is composed of 0.032 TMA. When activated, it wouldn't be parallel to the bracket, band, or tube. Let's look at the following case. C, D, and E still remain in case A, but only the second molar remains in case B. Lip bumpers are often used to obtain space. What problems may occur when using a lip bumper? In the case of A, the use of a lip bumper will induce backward movement of the first molar. This increases the possibility of the second molar being impacted. Also, for cases such as B, the use of a lip bumper could slightly delay the development of the mandibular second molar. Therefore, in such cases, we must be cautious when using the lip bumper. The lip bumper can also be used to prevent lower lip biting habits. The timing is very important when using the lip bumper, and it is recommended to use it to alleviate crowding of the anterior teeth after the mandibular first premolar erupts. In this case, we should first check the eruption pattern of the mandibular second molar before usage. We must understand the early mesial shift when checking the mandibular space. The space in the mandibular anterior region is called the developmental space, and the space in the mesial area of the maxillary deciduous canine and the distal area of the mandibular deciduous canine are referred to as the primate space. Permanent incisors are bigger compared to deciduous incisors, which can lead to anterior crowding at the time of exchange of anterior teeth groups. This mismatch can be compensated to a certain extent due to the developmental space. As the mandibular first molar erupts, the deciduous mandibular first and second molars move mesially and fill the primate space on the distal plane of the deciduous mandibular canine. As a result, the flush terminal plane becomes a class 1 molar relation. This is called the early mesial shift. The late mesial shift means that when the mandibular first molar moves mesially, using the leeway space as the mandibular first and second deciduous molars exchange. In the mandible, because permanent canines are bigger than the deciduous canines, we should check the space after permanent canines erupt. The mandibular second deciduous molar is 2 millimeters larger than the mandibular second premolar. The maxillary second deciduous molar is 1.5 millimeters larger than the maxillary second premolar. And the mandibular first deciduous molar is 0.5 millimeter larger than the first premolar. Therefore, we can get 2.5 millimeters of space per side in the mandible. For example, for a case with an erupted mandibular permanent canine, an acceptable profile and crowding which is less than 5 millimeters in the mandibular anterior teeth, we can use leeway space to obtain space. In the maxilla, when there is not enough space for the maxillary canine to erupt by approximately 3 millimeters after the first premolar erupts, we may use leeway space to obtain space. The arch length of the mandible is more or less preserved until the time when the mandibular canine erupts, but decreases as the first premolar erupts. It would be good to discriminate after the replacement of the 4 incisors of the mandible and the canine eruption. When should we pull out the mandibular deciduous canine? Unless it falls out itself, it's not recommended to pull it out in advance. Even if the mandibular deciduous canine shows a little degree of mobility, it is recommended to let it fall out itself as the permanent canine comes out. How should we design the lingual arch? We must apply a U-loop in front of the first molar and let the anterior wire touch the mandibular anterior cingulum. Since the buccolingual width of the mandibular first premolar is larger than that of the mandibular first deciduous molar, our design should not disturb the eruption of the first premolar. The mandibular second deciduous molar is already gone, and there is a space in the mandibular anterior tooth area. Is this space normal? No. We must lingually move the mandibular 4 incisors to close this space. To do this, the lingual arch should have space to prevent lingual arch from touching the mandibular anterior teeth. We can use 5/16 5/6 6 U's of light force elastics on the left and right soldered hooks. As mentioned previously, the wire should be located lingually around the first deciduous molar. We remove the soldered hook after closing the space around the mandibular 4 incisors. The lingual arch can be used to preserve leeway space and control late mesial shift and lower incisor uprighting. You obtain 2 to 4 millimeters of space to treat the crowding of the anterior teeth by removing the deciduous teeth and by using the lingual arch. In order to utilize the leeway space, it is recommended to use the lingual arch when the second deciduous molar remains. If the second deciduous molar is present and anterior crowding is observed, we can solve it by attaching a fixed bracket. Let's look at this patient. Tooth number 21 in the anterior region displays signs of crossbite and crowding. It will take time for the mandibular second molars to erupt. We must treat this immediately. In this case, should we maintain the space by using lingual arch, or should we obtain space instead? The goal of the first phase orthodontic treatment is growth regulation and rearrangement of the 4 maxillary incisors. If we rearrange the 4 maxillary incisors, the 4 mandibular incisors also gain extra margin for their corrections. We will decide whether to extract when the second phase orthodontic treatment is performed after the follow-up. For this patient, it is preferable to use Schwartz to obtain space in the mandible rather than to maintain space by using the lingual arch. To eliminate occlusal force when arranging Dr. 21, we can add PBB to the Schwartz. By rearranging the anterior teeth with partial correction afterwards, the problem would be solved. It is also possible to perform full bonding after extracting the second deciduous molar. But once we fix the anterior part, we may only need partial or no correction in the future. Let's see this patient. The maxillary second deciduous molar remains. Crowding is severe at tooth number 23, number 75 still remains. Slight tendency of class 3 malocclusion is observed. Which treatment should we perform? Maxillary TPA, maxillary fixed appliance, mandibular lingual arch, or mandibular fixed appliance? In MEO treatment, the mandibular second molar must be included. However, it takes time for it to erupt, so we must preserve space and wait for the eruption of the mandibular second molar. This patient still has the maxillary and mandibular second deciduous molars. Should we wait after installing TPA on the maxilla and lingual arch on the mandible? Before making our decision, we must consider the skeleton. Let's review the etiologic factors of malocclusion. The cause of class 2 malocclusion is the extrusion of the mandibular first molar at around the age of 8, when the deciduous canines exchanged. Therefore, for class 2 malocclusion, we must control the extrusion of the mandibular first molar. On the other hand, the cause of class 3 malocclusion is the overeruption of the first maxillary molar after age 12 to 13, around the end of permanent dentition. Therefore, for cases of class 3 malocclusion, the overeruption of the maxillary first molar must be controlled. As such, because the occlusal plane must be adjusted according to the skeleton, we must use different devices to preserve the arch length. Class 3 with the APDI over 85 degrees, we must wait after installing a TPA on the maxilla. In cases of class 1 or 2, we must wait after installing a lingual arch on the mandible. For maintaining space in cases with acceptable aesthetics, high combination factor, good lip seal, and borderline crowding, it is recommended to use TPA in the maxilla for class 3 and lingual arch in the mandible for classes 1 or 2. Unlike the maxillary TPA, we do not activate the mandibular lingual arch for rotation control. However, if the mandibular first molar is lingually constricted, the lingual arch must be activated to buccally upright it. The U-loop is required for such activation. By adjusting the U-loop, we can buccally upright and laterally expand the first molar. Many use lingual arch to obtain space in cases of mandibular anterior crowding. However, I use the lingual arch only when the mandibular first molar is lingually constricted. I recommend Schwartz appliance with expansion screws in the anterior part for mandibular anterior crowding. If the mandibular first molar is mesially inclined, we must activate the lingual arch to make it uprighted. We must first adjust the U-loop and cement it afterwards. We activate one side first and then activate the other side in 4 weeks. The problems with TPA or lingual arch are the decalcification and caries of the banded tooth. To prevent this, we should aim to minimize the term of their usage. But if long-term application is unavoidable, re-cementation must be performed between every 6 months to a year. Let's look at the indications of the lingual arch. 1. Space maintenance. 2. Anchorage reinforcement. 3. Buccal expansion in case of constricted lower arc scissor bite. 4. Traction of impacted anterior and canine teeth. 5. Traction of the impacted mandibular first and second molars. 6. Use of maxillary protraction appliances, such as face masks. 7. Traction in cases of posterior crossbite with buccally extended mandibular first molar. 8. Traction of transpositioned teeth. Habit control appliances for sticking out tongue, sucking fingers, etc. 10. Retention after treatment of the posterior occlusion. We will discuss the lingual arch indications in further detail in our next lecture, Arch Length Preservation Part 2. Thank you for watching.